So today we're going to be looking at non-cardiac chest, peritoneum and invasive procedures. But before we begin, please I want you to like, share and subscribe to this channel and put on your notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com, or you can WhatsApp me at +234 9019 144 175, or visit our online store at sonoeyes.business.site. Attempt the quiz in the description and leave me a comment at the end of the video. Now, normal chest anatomy usually will appear on ultrasound as alternating bands of shadowing related to ribs and reverberation artifacts that are caused by gas. Basically, that's what you see on a normal sonographic anatomy of the chest. Pleural anatomy, in this case, you're dealing with a delicate serous membrane that is composed of the visceral and the parietal layer. Visceral pleura covers the lungs and has a low sensitivity to pain. Parietal pleura covers the chest wall on the inside and has a high sensitivity to pain. Now, the pleural fluid lubricates the pleural surfaces. The pleural membrane basically separates the two lungs. Now, fluid collection are not generally demonstrated by sonography in a normal chest. Now, this image gives us an idea of the anatomic positioning of the lungs and the pulmonary vessels. Let's look at pleural effusion. Now, the fluid collection around the lung is referred to as pleural effusion, and readily can be identified during a sonographic examination of the abdomen. During abdominal sonogram, the lower chest should be evaluated for signs of pleural effusion. And what are the possible causes of pleural effusion? It could be infection, cardiovascular diseases, malignant cause, and trauma can cause it. In such case, you have hemorrhagic effusion. The clinical features you could find shortness of breath, chest pain, non-productive cough, in addition to the signs and symptoms that are related to the underlying cause. Now, this diagram shows what pleural effusion looks like. On the left, you see collapsed lung with air or fluid filled pleural spaces. On the left, you see a normal. On the right, you see a normal lung. Now, sonographic features of pleural effusion. Now, it could be simple pleural fluid or complex pleural fluid. In simple pleural fluid, you will see it as anechoic free fluid collection, which is on the dependent portion of the thorax, above the right or the left hemidiaphragm, in the right or left costophrenic angle or right cardiophrenic angle. Whereas in the complex fluid collection, it may indicate complex fluid collection basically will indicate infection or blood, that is hemothorax. Now, this image on the left shows a simple pleural effusion, and you see loculated pleural effusion on the right. Now, hemothorax can be as a result of trauma, necrotic neoplasm, or inflammation may cause hemorrhagic complex fluid collection. Then a pericardial effusion, this is anechoic fluid collection around the heart in the pericardial cavity, and this can also be noted during abdominal sonogram. A thoracocentesis is often performed to either determine the origin of the fluid in case of diagnostic thoracocentesis, or for therapeutic reasons, that is therapeutic thoracocentesis using ultrasound guidance, which we'll look at in a much later part. Now this image shows a collapsed lung that you see as an anechoic structure floating in fluid, echogenic structure, floating in fluid, which basically have the same echogenicity with liver or spleen. Then you see the fluid, the pleural effusion, the fluid area, which is the anechoic area. You can see the diaphragm, and the little ascites just on the other side of the diaphragm. Then on the left upper quadrant, you see pleural effusion, and you see compressed left lung. You also see the spleen, the subphrenic space, the diaphragm, and other structures. This is just to give you an idea what pleural effusion will look like on the left and on the right. Peripheral lung masses can be seen by ultrasound as long as they are about on the pleural and are not obscured by air in the lungs. It may be difficult to judge whether a mass is solid or cystic because the strong posterior interface caused by lung air makes assessment of through transmission difficult. Masses can be biopsied under ultrasound guidance. Masses can be detected by ultrasound, and such masses will include pulmonary sequestration or congenital cystic adenomatoid malformations in children. Peripheral located lung cancer, mediastinal tumors such as lymphoma and thymomas. Now, lung consolidation. Normal lung does not transmit sound because the air in the alveoli will reflect the beam. So consolidated lung is full of fluid, inflammation, blood, or neoplastic cells, and allows penetration of sound. So sonographically, lung consolidation may appear similar to liver or spleen tissue, but typically contains several internal echoes that radiate in a linear pattern because of air within the bronchi. Pleural effusion is commonly seen with lung consolidation, like you see in this image. You see lung consolidation. You can see a mass, the lung mass. Normally, you shouldn't see that if it's normal because of air within the lungs, but in lung consolidation, the lung is collapsed, so sound can pass through and you can now see, so you can see different cases of lung consolidation. Now let's look at peritoneum. Now the function of peritoneum basically is suspends and folds intraperitoneal organs. It secretes serous fluid to reduce friction between structures. The anatomy of the peritoneum is actually an extensive serous membrane that is lining the abdominal wall. It extends from the anterior wall to the retroperitoneum and parasternal tissues. It extends from the diaphragm above to deep pelvic spaces around the bladder. The fold of the peritoneum forms several potential spaces as it progresses along the internal, the abdominal cavity. So especially ligaments extend between organs in all these reflections. Fluid collections are not generally demonstrated by sonography in abdominal pelvic cavity where there is no pathology, where there is no ascites, where there is no fluid. Once it's normal on sonography, you should not see any fluid collection. A small amount of pelvic fluid may be identified in mid-cycle in ovulatory patients. Now, the greater omentum is a transparent double fold of peritoneum that spreads like an apron inferiorly to cover most of the abdominal pelvic cavity. It keeps the small intestine warm. The lesser omentum is a membranous extension from the portal fissure to the diaphragm. Like you see in this diagram, you see the greater omentum, the large broad sheet that flows down in the anterior abdomen. Then you see the parietal peritoneum that lines the inner surface of the abdominal cavity and all the other issues. And this image also gives you a coronal view and a sagittal view. Now the organs that are contained within the peritoneum includes the liver, the gallbladder, the spleen, stomach, duodenal bulb, jejunum, ileum, transverse colon, sigmoid colon, and uterine body. Every other organ not mentioned actually extra peritoneum. Now let's look at peritoneal spaces. Let's look at them one after the other and see and describe them. There is the subphrenic space. This divides into right and left subphrenic spaces by the falciform ligament. Right subphrenic space is located inferior to the diaphragm and superior to the liver and extends over several rib spaces to the right coronary ligament. At that point, you have the bare area of the liver. It includes spaces between the diaphragm and the right lobe of the liver. Left subphrenic space is located inferior to the diaphragm and superior to the spleen. Left subphrenic space includes spaces between the diaphragm, spleen, stomach, and left lobe of the liver. The subhepatic space extends from the inferior border of the liver to a deep recess anterior to the right kidney. It is the most common site for fluid collection. The lesser sac or omental bursa separates the pancreas from the stomach. It's located between the diaphragm and the transverse column. It communicates with the subhepatic space through the foramen of Winslow. Morrison's pouch or hepatorenal pouch, located superior and anterior to the right kidney and posterior to the lateral portion of the right lobe. It communicates below with the right paracolic gutter. Unable to communicate with is unable to communicate above with the right subphrenic space because the right coronary because of the right coronary ligament, which creates that bare area of the liver. It is frequently the site for collection of fluid. Paracolic gutters is located lateral to the colon on either side of the abdomen, serves as a conduit for fluid between deep pelvis and upper abdomen. The right paracolic gutter demonstrates less resistance. It is a more common route for fluid extension to and fro the pelvis and the upper abdomen. So the left paracolic gutter is actually shallower than the right. Now a quick look at the pelvic spaces. We have the retropubic space. It is located anterior to the urinary bladder and posterior to the symphysis pubis. It is also known as the prevesical space or space of Rhesus. Retrovesical pouch is located posterior to the urinary bladder and anterior to the rectum in male. Retrouterine pouch is located posterior to the uterus and anterior to the rectum of the female. It is also called posterior cul-de-sac or pouch of Douglas. Vesicouterine pouch is located posterior to the bladder and anterior to the uterus. It is also called anterior cul-de-sac. Like you see in this image, the vesicouterine pouch, the rectouterine pouch is a pouch of Douglas, and other anatomy. Now, peritoneal fluid collection. Fluid collection can be localized or organized. Yeah, an example of such will be abscess, hematoma, biluma, seroma, urinoma, lymphocyst, pseudocyst, or pseudopancreatic cyst. Whereas free fluid collection will include benign ascites, malignant ascites, hemoperitoneum, and pseudomyxoma peritoneal. Let's take abscess. Usually the etiology for abscess is infection. Inflammatory fluid collection may localize in any potential space of the abdominal pelvic cavity, whether it's subphrenic, subhepatic, Morrison's pouch, pelvic cavity spaces. These are all common areas where you can have collection of abscess. Clinical features will include pain, fever, chills, rigor, leukocytosis are cardinal signs. The sonographic features include a complex mass, which is really common, is more common. You can have, you see irregular thick walls. Displacement of adjacent structure will occur and may show septations, internal echoes, debris, fluid debris level, and posterior enhancement. And usually this mass is non-vascular mass. But however, the differential diagnosis for these will include hematoma, complex ascites, lymphadenopathy. And this is an example of abscess, different ways they can appear. So this, the image A is at the right upper quadrant, abscess in the right upper quadrant. Then you can see still in the right upper quadrant, just around the left lobe, you can see the appearance of abscess with gas formations already appearing. Then you can see abscess around the left kidney. Hematoma or hemoperitoneum. The etiology is basically recent surgery, rupture blood vessel or aneurysm, rupture ectopic pregnancy, trauma, fistula, necrotic neoplasm, and so on. The clinical features will be abdominal pain, decrease in hematocrit, and shock. Sonographic features, it will include anechoic cystic mass. It could be echogenic, depending on the time you are scanning from the onset of the hematoma. Mixed or hypoechoic fluid collection, depending on the duration of the hematoma. It's often difficult to distinguish from abscess, but the clinical features and decrease in hematocrit is diagnostic. And this is an example of hemoperitoneum. You can see floating bowel, the liver is separated from the right kidney and pushed aside. Now, urinoma, the etiology is urinary tract surgery, stone, tumor may cause rupture of the urinary outflow tract and collection of urine in the potential spaces. So clinical features include oligouria, anuria, renal failure, and abdominal pain. Sonographic features, an echoic cystic mass, round or oval in shape, well-defined walls because it has been walled off, posterior enhancement, and frequently it shows septations. And this is an example of urinoma. You can see already there is severe hydronephrosis, and urinoma is formed outside because of the leakage. Then urinoma around the pelvic area, and the bladder is pushed upwards. Lymphocyte is the accumulation of lymphatic fluid. Commonly, we see as a late complication of renal transplant, vascular urology, or gynecological surgery. Clinical feature may be asymptomatic, may have ipsilateral leg swelling. Sonographically, the features you see is anechoic cystic mass, frequently containing septations and posterior acoustic enhancement, well-defined wall margin, round or oval in shape, more commonly found medial to the renal transplant immediately after surgery. The differential diagnosis in this case will be seroma, urinoma, or loculated ascites. Seroma, the etiology for seroma is trauma and surgery. Clinical features is basically asymptomatic. Sometimes you have abdominal pain or discomfort. And the sonographic features you see is anechoic mass, smooth wall margin may conform the you have smooth wall margin and may conform the shape of the surrounding structure. Differential diagnosis for seroma will biloma, urinoma, lymphocyte, and hematoma. Now, benign ascites, the etiology basically will include CCF, congestive cardiac failure, cirrhosis, nephrotic syndrome, hypoalbuminemia, protein energy malnutrition, portal hypertension, infection, and inflammation. The clinical features will be abdominal distension, of course, pain. Sonographic findings will include anechoic free fluid collection in the peritoneal cavity, mobility of fluid with patients change in position. Bowel may appear floating within the fluid. If it's minimal, more commonly it will be located in the subhepatic spaces, Morrison's pouch, followed by the paracolic gutters in the supine position. Gallbladder wall will appear thickened due to signal amplification artifacts, and it's called sympathetic thickening. Malignant ascites. Etiology is basically metastasis. Clinical feature, abdominal distension, pain, discomfort, you have weight loss and other cancer stigmata. Sonographic features is an echoic free fluid collection in the peritoneal cavity. There is also these low level echoes which will be maybe demonstrated. The bowels are usually matted down, unlike benign ascites where they are everywhere. Gallbladder wall normally will show normal thickness. That sympathetic thickening will not occur. Alright, so pseudomyxoma peritonei, the etiology is due to ruptured mucinous cyst adenoma or mucinous cyst adenocarcinoma. The clinical feature will include abdominal distension, abdominal pain, discomfort, commonly in elderly women. Sonographic feature, you have anechoic fluid collection in the peritoneal cavity, internal echoes or echogenic linear strands or peritoneal seedlings. You could have multi-septate cystic areas which will be demonstrated in the peritoneal cavity. The bowels are matted and compressed posteriorly. The gallbladder wall is usually normal. So this image shows example of different appearance that you could have in pseudomyxoma peritonei. You can see so in this first image is just basically the appearance you have in the mucinous cystic adenoma. Well, again, it's ruptured. Then in this case, it's ruptured and most of the fluid are flown out, and all those descriptions we just told you is what it is. Peritoneal masses will include mesenteric cysts, omental cysts, and lymphoma. Mesenteric cysts, basically, you have a congenital, Wolffian, or lymphatic duct in origin. That's where it's come from. Clinical feature may be asymptomatic, colical abdominal pain, or intestinal obstruction. In sonography, you have an anechoic cystic structure located in the mesentery, small wall margin. You have a small wall margin. It is not associated with any adjacent structure. Most commonly, it is located in the small bowel mesentery. But again, the differential diagnosis here will be renal cyst, hematoma, abscess, neoplasm, or ascites. Omental cysts usually will occur from congenital failure of mesentery to fuse, and also trauma. Clinical feature usually asymptomatic. Sonographic appearance is a small cystic structure that's located adjacent to the stomach or the lesser sac. You have a smooth wall margin. The mass will contour to the bowel margin and may show honeycomb appearance. Differential diagnosis includes renal cyst, pancreatic pseudocyst, hematoma, abscess, neoplasm. Lymphoma could be Hodgkin's or non-Hodgkin's lymphoma. Clinical feature, superficial abdominal mass. Sonography feature, you have superficial, thick hypoechoic mass that follows the shape of the anterior wall and lateral abdominal wall. Now let's look at invasive procedures. Ultrasound can be used to guide invasive procedures. Typical procedures in which the ultrasound guidance is used will include drainage of pleural effusion, biopsy of chest masses, aspiration of ascites, abscess drainage, liver, spleen, pancreatic mass biopsy, renal parenchyma or renal mass biopsy, prostate mass biopsy. Ultrasound guidance can be performed whether freehand or using a needle guide. Guidance can be performed in a freehand fashion by putting needle at a 45-degree angle to the ultrasound beam. This is ultrasound beam, and this is the needle 45-degree angle. Usually the ultrasound beam should be perpendicular to the patient's surface. Then the needle should be angled 45 degrees to the ultrasound beam. Now this technique is best used when there is fluid around the target. Needle can be inserted into the guides located along the transducer, allowing the needle to follow a predetermined track. This technique is often used in prostate and liver biopsy. Various techniques exist to improve needle visualization. Now, the greater the angle of the needle to the beam, the easier to see it. Now, this image shows you how that is done and should be done. And on the right hand side, you see what the needle will look like on ultrasound, and the arrow indicates the echoes coming from the needle. And now this needle guide with which is fitted on the transducer. And now this is how it's done with ultrasound guide. Now, when you use the needle guide, there is a predetermined track. The dotted lines indicated by the yellow arrows, that's the track in which the needle will follow to the target tissue or fluid. Now this also shows you the needle track into the body across the several layers of the anterior abdominal wall. So I want to thank you for this lecture, for joining us. Please like, share, subscribe, and put on your notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com, or you can WhatsApp me at +234 9019144175, or check our online stores at sonoeyes.business.site. Attempt the quiz in the description and leave me a comment. Until the next time when I come your way again, keep learning ultrasound.